This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, this is an elderly lady who has this very dense hypermature cataract and she's been posted for surgery. The pupil is very well dilated. There is a thick carcass, but the visibility as such is quite alright. And I've decided to proceed with phaco emulsification. And some of the concerns which I'm going to have while doing surgery for this patient would be the difficulty in cracking the posterior plate of the nucleus, which is I'm expecting it to be quite hard. And since it's an elderly patient, the capsule and the zonules might not be of great health. So during the creation of the small fragments, I should be focused on not imparting any stress on the zonules. And the second important factor always would be to ensure that the corneal endothelium does not encounter any trauma. Now, since the cataract is extremely dense and the patient is elderly, so we need to take every possible precaution to ensure that the endothelium does not bear the brunt of the trauma during the surgery. So these are the two primary concerns, and I'm planning to take adequate measures to deal with them. Now, since it's a dense cataract, I feel by using the torsional energy which is available in our phaco machines, which has got an excellent cutting ability, we can use this cutting efficiency to core out the nucleus, and that's the reason I'm going to use the divide and conquer, the classical 4-quadrant technique, simply because when you core out majority of the nucleus, the difficulty which is encountered to fracture the posterior plate is relatively lesser than attempting a direct chop. So that's the reason why I'm going to use the 4-quadrant technique in this patient. And to protect the endothelium, obviously, two things to be done. Refill of the OVDs at every opportunity possible. And the second would be to just monitor the plane of emulsification. I want to do it as posterior as possible, and let's see how things turn out. Incisions are made, the capsule is stained, dispersive OVD goes in first, coating the endothelium. While planning the rhexis, I need to be mindful that it has to be at least 5.5 or bigger than that. Smaller rhexis is definitely a no-no in this eye, simply because if you have a smaller rhexis during the nucleus manipulation and when you're trying to divide them into smaller fragments, there's always a risk of imparting stretch on the rhexis margin. So that's the reason it's mandatory that we should have a bigger rhexis in such situations. I'm not doing any hydrodissection and just trying to feel whether the nucleus is attached to the capsular bag or something. So usually sometimes in very long-standing cataracts, the nucleus would be very firmly attached to the capsular bag. In this case, it doesn't seem to be. I'm not going to do the classical hydrodissection. Just nudge on the nucleus and see it's relatively free. Time to phaco. In this case, I'm using the infinity machine and I'm using the balance tip along with it. The initial epinucleus over the surface of the nucleus is aspirated out. Time to sculpt. I'm just going to add the screenshot of the machine settings for the sculpt procedure. You can see I'm going to use only the torsional energy with very low vacuum and flow rate. The nucleus is stabilized with my second instrument. The phaco tip starts from the subincisional rhexis margin end, and then it is moved towards the opposite end of the rhexis margin. Mind you, this is a hard cataract and the eye would be having compromised zonules. We should use the phaco power to cut through the nucleus rather than using any mechanical force. So you need to ensure that as the probe is moving forward, it has to be very effortless. It should not induce any stress on the nucleus which can be imparted to the bag. And we should literally see the nucleus melting in front of the tip as it is going to and fro. Once I've got around 50% depth, the nucleus is rotated 90 degrees and a new trench is being created. As I go more posteriorly, the nucleus starts to move a little bit when I'm sculpting. That is because the nucleus has become much more harder than what the power which I'm using. So again, I need to be very gentle, and using the left hand to stabilize it is going to be very helpful. The second reason why it can move is, as you can see, I don't want to make a very wide trench, but what's happening here is that the sleeve which is there is actually getting obstructed by the walls of the trench. I'm unable to go very long into the trench, and also the nucleus is being pushed at because of the sleeves which are obstructing the walls of the trench. So I'm just going to widen it just a little bit, but I can't widen it too much. If I'm making it too wide, I'll not have enough support of the lateral walls of the trench to do the separation maneuver. So that is the reason I need to have a compromise in the width. The nucleus is rotated and the trench is continued. Every progressive trench which we make is going to be much more deeper than the predecessor. So you keep on rotating the nucleus and keep on sculpting it, and the eventual goal in this case is to go at least 95% depth so that it would not be very difficult to crack the posterior plate. The most important attribute a surgeon can have in such cases is to have truckloads of patience. It's really going to test your patience, but you don't have to hurry. And if you're calm and patient, the hardest of the cataracts can be easily broken down. We can notice that there is a slight color shift here. The central 3mm of the nucleus still continues to be dark brown, whereas the color of the bottom of the trenches in the peripheral parts is slightly much more darker or blacker. So this is an indirect evidence that the plate is much more thinner in the posterior part, but still continues to be very thin in the central part. Now I think I have gone at least 90 to 95% depth now. I would be wanting to start to crack. So time to do the lateral separation maneuver. I can see that the posterior plate is really thick. I'm trying to place the two instruments, the phaco tip and the long chopper, as posteriorly as I can, and then I'm trying to do the lateral separation maneuver, but it is not good enough to crack this very thick and leathery posterior plate. So I changed strategies. I'm going to go to the chop mode, try to bury the phaco tip inside, and then do the lateral separation maneuver. Here, my right hand with the phaco tip is actually pulling the nucleus fragment a little bit up, and then I'm trying to do the lateral separation maneuver. The peripheral part of the posterior plate is broken, but the central part refused to give way. It's way too tough. So in such situations, again, I said being patient is good enough. Just leave the fragment, rotate the nucleus, go to the next quadrant and try to deal with it. Again, you can see I'm holding the fragment, pulling it up a little bit, and then trying to do the lateral separation. The peripheral part of the posterior plate is cracked, but still the central part, that is the central 3mm of the posterior plate, continues to hold on. The nucleus is rotated again, and the pupil is come down a little bit. Whenever you lose a grip, there is always a risk of catching hold of the iris. So just come out here, inject a little bit of OVD, buy some time, push back the nucleus back into the capsular bag, and now I'm going to use two long Sinskey hooks to attempt lateral separation. By this I'm hoping that I'll be able to reach the most part of the groove and then attempt the lateral separation. So one part is free now. The posterior plate could be broken through and through. The nucleus is being rotated. So when you're trying to do this lateral separation maneuver using the two long Sinskey hooks, it's important that the chamber has to be maintained deep. So if the OVD has escaped out, come back, refill the OVD, and very patiently keep placing the two instruments as deep as possible. The only difficulty which we face is our ability to place it exactly near the posterior plate. That's the reason why we need to see well and ask ourselves whether the position is right. So once one tip is free, it is just hold it and pull it out of the bag and then emulsify. So the plane of emulsification is again extremely critical. I want to be at the level of the rhexis margin. Now we're close to the endothelium. Now because we have got such good cutting ability with the torsional energy, emulsifying this big quadrant, it's not going to be difficult at all. Please note, after every fragment, combination of dispersive OVD first and then HPMC underneath is being put. The second free fragment is then maneuvered in a position where I can reach it. The phaco tip goes in and engages it, pulls it out of the bag, and the emulsification is being done at the level of the rhexis margin. Coming to this remaining heminucleus, the posterior plate in this is still not separated. So I'm going back, refilling the bag with OVD and trying a lateral separation maneuver. And it doesn't work. So what I'm trying to do is trying to do it with my phaco probe itself. Hold the phaco probe, engage one of the nucleus and try to do it. Even that doesn't work completely. So what I do now is my technique of flipping up the base and then phacoing it. So the junction of the bridge which is holding these two fragments together is maneuvered out of the bag at the level of the rhexis margin under the cover of viscoelastic, and then using the sculpt setting, the bridge is broken by direct phaco. So this is possible only when we have enough space in the bag. So this is a very effortless and stress-free way of breaking the posterior plate in these ultra-dense cataracts. Once the fragments are free, they are again pushed back into the bag, and each of them is then emulsified in a very controlled manner. So before we go to the cortex aspiration, let me share with you the screenshot of the energy which has been consumed, and it's quite significantly high in a denser cataract. And the common perception is that the cornea will take a hit and you'll have significant post-op edema in the weeks to come by. Let's see how things turn out. There's hardly any cortex to remove, but whatever few fibers are there are then being aspirated. The bag is filled with OVD. The planned lens is placed into the bag. The OVD both in front and behind the lens is aspirated out. And that's it, the case is done. And these are the first day post-op pictures, and the cornea is pretty clear. So one assumption that, using excessive energy is going to cause endothelial damage and persistent corneal edema is, I have not found it to be true. What's important is the plane at which you deliver the energy and how much less you can minimize the mechanical trauma to the endothelium. These are the two factors which actually decide the endothelium. And second question always asked is like, what happens to the long term? So I have followed them for many cases. I have not noticed any long-term or progressive loss of the endothelial cells leading to an endothelial cell decompensation or something. That really doesn't bother me because I have been using this for some time now, and that has never been my experience. So that shouldn't be a concern in my opinion. So to summarize, breaking the posterior plate is a challenge. So the secrets are, number one, your trench has to be as deep as possible, probably 95%. And invariably, we are always not as deep as that cataract deserves, especially the denser ones. While doing lateral separation, it's important that we place the instruments as deep as possible, literally touching the posterior plate and then do it. And that is the most difficult part of the lateral separation maneuvers. And finally, if we can get one piece out, we can always maneuver the base of the trench up by using viscoelastic, flip it up, and then phaco this bridge which is holding the pieces together using just the sculpt settings. That's the most simplest way of taking care of these small attachments of the posterior plate in the thickest part. And finally, when you have got all these fragments done, emulsify them at the right plane. That's very critical. That was it. Thank you for watching and hope you found this helpful.